السلام عليكم ورحمة الله وبركاته. كل عام وأنتم بخير. متأخرة بالنسبة لعيد الحج ومتقدمة بالنسبة للسنة الجديدة. خير ما نبدأ به هو بسم الله الواحد الأحد الفرد الصمد، والصلاة والسلام على من لا نبي بعده سيدنا محمد وعلى آله وصحبه وسلم. It's a great honor for me, Dr. Ali Sultan, consultant endocrinologist at Salama Hospital, Jeddah, to be with you this Friday afternoon. Very grateful to everybody, especially survey who were dedicated from the beginning of my career. I will mention it in 2000 until now, to the educational and scientific part for all aspects of metabolic diseases which concerned us as an endocrinologist, as an internist, as a nephrologist, and cardiologist as well. So this afternoon, people who left their family and were with us are online to go for a very important issue. And the importance of this issue will be elaborated through 3 lectures today, and I will be the chairman of this session. This is a Cardiometabolic Connect, bridging the knowledge and care. Next, please. So, why we are gathering this afternoon? This is really important issue in our area, the MENA region. And within the MENA region, the Gulf state, the real life data showed that acute coronary syndrome registry in the Gulf have a 34,000 patient over 15 years, but they are unique. They are not like other parts of the world. Our patients are 15 years younger, and they have high risk factor for left ventricular dysfunction and severe diffuse coronary artery disease. These data out of the registry from a very prestigious Gulf studies. So, as you can see, in our patients, there are only 10% who are only diabetic. And as an endocrinologist, in my patients, I always look for their blood pressure and lipid profile. And to have a pure type 2 diabetes, as per the studies with multiple morbidity challenges from single one, it's rare. But to be combined with hypertension, it goes up to 18%. And when dyslipidemia come 16%. But the presence of these 3 high-risk issues in the diabetic patients will be 56%. More than half of our patients have the 3 together. Maybe, if you allow me to speculate, diabetes on the background, followed by high blood pressure with the presence of dyslipidemia, the 3 will join and cause the acute coronary syndrome. The worldwide data for multi-morbidity and its high prevalence, and shown here, a review of 126 peer-reviewed study included 15.4 million around the world, shows the percentages. And we cannot be except part of the highest among the world in our region and Asia as well. These 35%, if we reflect it in some area, especially our MENA region, it might be higher than the rest of the Asia country. So today, the Cardiometabolic Connect will bridging the knowledge and the care, and it's an educational platform. You can scan this barcode to join it, and it is focusing on the cardiometabolic diseases, providing up-to-date medical information, connecting with experts to ask platform which have this unique part, which you will be able, through putting your question, and eminent references in the field will be able to get answers for your difficult questions.
Welcome to Medical WeBook on Cardiometabolic Connect, bridging knowledge and care in a truly innovative way. Structured like a traditional book, the platform is divided into chapters and paragraphs. But here's the twist. Each paragraph is brought to life with dynamic, TV-style video content designed to engage and educate. You can add personal notes directly into the content and search them anytime, making your learning truly personalized. Got a question or insight? Use the private messaging system to connect directly with experts. And when you're ready to go deeper, additional resources are just a click away. Medical WeBook, where modern learning meets clinical excellence.
Very nice platform, and I hope it will be useful for everybody. So as you have seen, the 56% of our patients will be hypertensive, dyslipidemic, and diabetic. So we will start by the first speaker, Dr. Tarar Urebi. He's a consultant in internal medicine, infectious disease control, and he is working at Sulaiman Al Habib Hospital Group, Riyadh, Kingdom of Saudi Arabia. So hypertension beyond blood pressure control. The floor is yours, Dr. Talal.
السلام عليكم ورحمة الله وبركاته جميعا. تقبل الله جمعتكم. كل عام وأنتم طيبين. First of all, really I'm thanking you, Prof. Ali, for your excellent introduction. And I'm thanking Serfia, as you mentioned, Prof. Ali, that really they are all the time supporting an excellent meeting, clinical gathering, and educating all people in the medical field and providing an excellent molecule in controlling the hypertension and other metabolic syndrome diseases. As you know that the leading cause of death globally, as mentioned by Prof. Ali, is due to the cardiovascular disease in general. And the cardiovascular continuum, it's an endless circle. It starts by hypertension, dyslipidemia, chronic endothelial damage, leads to coronary artery disease, myocardial ischemia, stroke, and etc. And as you know that all diseases related to the atherosclerosis and cardiovascular disease is most likely started at the younger age by early accumulation and uncontrolling the risk factor like the dyslipidemia and hypertension at younger age. Then later on, at an age beyond 50, the risk accumulation increased, and those patients, they developed an cardiovascular events. The role of endothelial injury or dysfunction in cardiovascular disease is a well-known and established chronic inflammatory process that leads to formation of atheroma due to an accelerated process and stressful conditions, including diabetes, hypertension, obesity, infection, dyslipidemia, high homocysteine, uric acid, smoking, and other risk factors. In general, we can distribute it into a modifiable risk factor and non-modifiable risk factor. The non-modifiable risk factor, probably the most one, is the genetic predisposition, but most of the modifiable risk factor, it's in the hand of the patient and his physician. And by addressing such risk factor, and the number one risk factor is hypertension, by controlling the hypertension early in disease recognition is associated with decrease the early cardiovascular events. Arterial stiffness. So arterial stiffness, it can precede by many years. In the clinical practice, it's not probably easily to be detected, but based on the studies, it can anticipate earlier the cardiovascular risk factor. It's a complex mechanism. It started by sympathetic modulation, atherosclerosis, central nervous system reflection, large artery stiffness, pulse pressure, and hypertension, endothelial damage. So it's all connected together, and over years, it can lead to cardiovascular events. So the correlation between number of risk factors and arterial stiffness. So arterial stiffness, brachial artery distensibility occurs long before the clinical manifestation of cardiovascular disease that can appear. And you can see that the linear trends and the number of cardiovascular risk factors, it can be reflected early before the development of cardiovascular events. This is an important figure, and you can see the top on the left side. There is a summary, the correlation between the endothelial dysfunction and the hypertension. And the hypertensive patient have impaired endothelial function. So in the left graph, they compare the normal control with hypertensive patients. After administration of acetylcholine, which normally stimulates the endothelial nitric oxide release and vasodilation, blood flow increased markedly in healthy individuals. In hypertensive patients, the increase in blood flow was significantly blunted as shown in the figure. And this indicates the endothelial dysfunction characterized by reduced nitric oxide mediated vasodilation. On the right graph, they compared the normotensive individuals with or without a family history of hypertension. Subjects with a family history showed a significantly lower vasodilatory response to acetylcholine despite having normal blood pressure. This suggests that endothelial dysfunction may be an early abnormality that occurs before hypertension develops. And the clinical implication of this, the consequences of hypertension, vascular damage from elevated blood pressure, and a contributor to hypertension development, a nitric oxide increase the vascular resistance, and reduced endothelial nitric oxide production can lead to vasoconstriction, increased peripheral vascular resistance, vascular remodeling, and progression to hypertension and atherosclerosis. As you know, the balance and the effects of angiotensin to nitric oxide balance, it's a balance. You can see the bradykinin and nitric oxide and angiotensin 2. There is a balance between the vasodilation, vasoconstriction on the right side, arterial compliance, and anticoagulation, anti-inflammation, and on the right side, the hypertrophy, hypertension, and thrombosis. So it's a balance between the both arms. So cell proliferation that leads to collagen synthesis in the vascular smooth muscles that lead to the thickening of the intima. Then over years, it leads to arterial stiffness. This is a chronic process The acceleration, it depends on the patient profile, his genetic predisposition, his smoking history, and other risk factor. So the thickening of the vascular media acceleration, it can be delayed even if there is a genetic predisposition by controlling the modifiable risk factor. And one of the most important modifiable risk factor is hypertension treatment with appropriate agent. So there is many patients, they receive their appropriate antihypertensive medicine to control numbers, but the pathophysiology behind that one is still running and not well controlled. So the damages to the endothelial leads to endothelial apoptosis, and later on is associated with vascular remodeling and increase the inflammation and thrombosis and ultimately atherosclerosis and hypertension. Mechanism of action differs between ACE inhibitor and ARBs. As you know, the mechanism and the summary of this graph, ACE inhibitor examples, enalapril, lisinopril, ramipril, printopril. So it blocks the conversion of angiotensin 2 to angiotensin 1 to angiotensin 2 that reduce stimulation of AT1, AT2, and AT4 receptors that prevent degradation of bradykinin, leading to increase the bradykinin level. The ultimate effect of this one leads to decrease the vasoconstriction, decrease inflammation, decrease endothelial apoptosis, increase bradykinin mediated endothelial stimulation, and increase angiogenesis and vascular repair in the ischemic tissues. And the clinical implication of this one is a strong endothelial protective effects, and it delayed the probably acceleration of inflammatory process and atherosclerosis by doing excellent effort with the mechanism mentioned above. That leads to decreasing the early atherosclerotic events or cardiovascular events. ARBs or angiotensin receptor blockers, still one of the important treatments in the era of hypertension management. Examples, losartan, valsartan, telmisartan, candesartan. It selectively block the AT1 receptors and can still stimulate AT2 and AT4 receptors. And usually level. So the bradykinin level probably is elevated in the ACE inhibitor because it's blocked the pathway from the start, but in ARBs, usually the late that block the receptors at selective at AT1 receptors. That is why the bradykinin level in ARBs is lessly elevated. That is usually contributed to the minimal cough in ACE inhibitors. The effect is excellent, but it lacks comparing to the ACE inhibitor. The inflammatory process inhibition is less, endothelial apoptosis is less, angiogenesis and vascular repair in the ischemic tissue probably is less. And that ultimately lead to less endothelial protection. The evidence supporting the benefits of ACE inhibitor in coronary heart disease is well established with many excellent studies as mentioned in the figure. HOPE trial, the HOPE trial summary and the outcome regarding the MI, stroke, and fast cardiovascular death. It decreased 15% reduction in infants at 1 year with rimipril comparing to the placebo group. And this is an excellent relative risk reduction of 22% and 15% reduction in infants at 1 year. Europa trial, this is the primary outcome of cardiovascular death, MI, cardiac arrest. They compare the brindopril to the placebo, and it's excellently showed a relative risk reduction of 20%. This slide is an excellent slide in patented study that lead to significant reduction in level of angiotensin 2. So I will highlight and I will discuss this slide. Is a very important slide. And the bottom line of this slide in the patent study, it showed that those patients with received Brindopril comparing to the placebo, you can see the level of 14.8 and then 17.7 at 1 year, and from the baseline increase in the bradykinin. And this has an excellent protective effect on patients started on Brindopril. This is a slide showed significant reduction in apoptosis on those patients that are receiving Brindopril comparing to the placebo in coronary artery disease patent patients. And this is an excellent pathophysiology or mechanism of protection, usually with ACE inhibitor, especially Brindopril. ACE inhibitor and apoptosis, you can see in this slide that the lipopolysaccharide markedly increased in patients with apoptosis, endothelial cell apoptosis from 0.8% control to 17 to 10.7, demonstrating significant endothelial damage. After 1 week of ACE inhibitor, all ACE inhibitor reduced the apoptosis, but with different percentage. You can see that Ramipril 7.5%, Enalapril, for example, 10%, but there is a different and significant difference with Brindopril. And Brindopril, usually it causes the greatest anti-apoptotic effect, reducing the apoptosis by 4.3%, and one of the lowest or the most potent ACE inhibitor in reducing apoptosis. So the effect of Brindopril versus Valsartan on endothelial cell apoptosis post-patient with acute myocardial infarction, you can see from the baseline to day 30, there is an excellent reduction in apoptosis in Brindopril comparing to the Valsartan. And the main mechanism beyond this one is the decreased inflammatory process and apoptosis that lead to excellent recovery for the cells. Advanced trial, summary of the advanced trial, the combination of Brindopril and indibamide with calcium channel blocker provides substantial reduction in both all-cause mortality and cardiovascular death. Guidelines, statement of guidelines nowadays is clear to everyone. ACE inhibitor or ARBs, if not tolerated to the ACE inhibitor, you can start ARBs, is a clear statement, and then you can choose the second one if the patient did not approach his target blood pressure level. So ACE inhibitor has been shown to reduce the cardiovascular outcome in high cardiovascular events and preventing the high-risk patients with hypertension and atherosclerotic cardiovascular disease from starting an ACE inhibitor without a clear justification and a clear reason, just like a simple unexplained cough that can be explained by many reasons, not interfering with patient lifestyle or sleep, is very serious, especially those patients who already has an established acute myocardial infarction or an stroke due to an hypertension. So please do not switch the patient unless you have a clear justification, either a clear justification from drug hypersensitivity that been documented and related directly to the drug. So many of our colleagues, they are jumping and early switching the patients, and they are not knowing the benefit and the deep pathophysiology that really has been discussed for the last 3 decades in comparing AC inhibitor and ARBs arm to arm and seeing as I mentioned, AC inhibitor is more appropriate for patients with acute MI compared to ARBs that been shown clearly in the figure. So again, the guidelines highlighted the importance of AC inhibitor in reducing the death, and it stated the first option. If the patient did not tolerate, you can go to the next option. So you can choose for your patient with hypertension and heart failure with HFpEF, you can use AC inhibitor or ARBs plus calcium channel blocker plus diuretics. For sure, nowadays there is a strong evidence for the SGL2 inhibitor for all of the patient unless there is a contraindication, and you need to monitor your patient by increasing the doses or decreasing the doses according to the response. But still, AC inhibitor is a cornerstone in managing patients with hypertension, HFpEF, or hypertension with heart failure and even reduced ejection fraction. This is again a guidelines in European Society of Cardiology in Managing Hypertension and CKD, and it highlighted the importance of uh, AC inhibitor in those patients, and you need to be very careful in monitoring the creatinine on those patients, but doses it needs to be handled by an expert person to monitor the creatinine. And before you start the AC inhibitor, those patients, they do have a mild increase in their creatinine that can be later on improved with time. So AC inhibitor and ARBs, different mechanism and different effects, and you can see, as I mentioned through my talk, AC inhibitor it block early the pathway that leads to an elevation of a bradykinin, an excellent effect decreasing the inflammatory process and atherothrombosis, and it has an excellent improvement in apoptosis comparing to the others. AC inhibitor, not ARBs, showed significant reduction in plasma level of inflammatory markers such as a C or high sensitive CRP and TNF alpha. So this is in studies, but it decreased the inflammatory process, as we know that high elevated and high sensitive C-reactive protein associated with accelerated atherosclerosis. So probably those with high risk factor, you need to monitor their high sensitive CRP and to make sure that it's in the lower side. So there is a new data confirm the stronger cardioprotection with AC inhibitor versus ARBs, and it's shown in this meta-analysis. AC inhibitor were reported to be the most effective in reducing the risk of myocardial infarction by 28%. Only AC inhibitor decrease the risk of myocardial infarction, as shown in this figure, and the different effect of AC inhibitor and ARBs on the risk of myocardial infarction compared to the placebo. And you can see in the figure, there is a significant reduction in the arm of Brindopril versus placebo in HOPE trial and Europea trial around 20 to 22 respectively. Which ACE inhibitor does it matter and how in controlling the hypertension risk factor and apoptosis? Probably through the lecture, if you remember that the prindopril is one of the excellent molecule for the following mechanism and is considered one of the most long-acting ACE inhibitor that probably covering around a 24 hour. And this is what you needed for nocturnal hypertension that decrease the flip up during fluctuation of hypertension while the patient is sleeping. So you assure that your patient is controlled around the clock. So all-cause mortality and effect of ACE inhibitor. Overall, you can see the studies that supporting the effects of ACE inhibitor as its benefit. Now, it's well established and no doubt about its benefit. So when we combine the prindopril, amlodipine, and diuretics, or prindopril, amlodipine alone, so each other is decreasing the side effect of the other one. So the prindopril, the cough, it decreased dramatically when you are combining it to the amlodipine, and the other side, the lower limb edema, usually is decreased significantly when combined it to the prindopril, but combining together is well excellent molecule that cover the 24 hour and leads to an excellent blood pressure control around the clock. So ASCOT trial is a 16 years of follow-up, 29% fewer stroke death, 21% less cardiovascular death, patient treated with atorvastatin, and 15% less cardiovascular death compared to the placebo group beyond the blood pressure efficacy. So leads to less than 24% death reduction when comparing to the other molecule. So the long-acting and this excellent study showed the significant benefit of the combination treatment. Prindopril, indapamide, amlodipine has a proven life-saving benefit, especially those with difficult to treat hypertension, and leads to mortality reduction in around less than 20% reduction. Conclusion, high blood pressure today is still the leading cause of death globally. In our MENA region, we are in latest studies around 10 years younger in developing atherosclerotic cardiovascular events comparing to the whole world. The leading cause is hypertension. Despite substantial increase in number of antihypertensive drugs, the rate of blood pressure control, especially nocturnal hypertension, is not being well established and not being controlled well, giving an excellent combination molecule that cover the 24 hours, decrease the fluctuation of blood pressure readings that lead to end organ damage. To improve this situation, we need to fill the gap between the guidelines and clinical practice. We have high prevalence, low awareness, and many patients, they are not controlled. Please follow the guidelines, instruct your patients. Three-dimensional management of their hypertension usually lead to excellent results. Thank you.
Thank you very much, Dr. Talar. You went with us in a very nice journey, proven data with a very nice study, and the experience and the data of 30 years cannot be explained and displayed better than the way you did.
Thank
This
you.
is
Thanks for my
the QR code for joining the medical book. If you like to join, please scan the barcode. Dr. Talal will be with us for your Q&A after the and the end of our lectures.
My pleasure all
So
the time. Thank you, Dr. Ali. My pleasure.
Yeah, the pleasure is for us, Dr. Talal, to have you with us this afternoon. Okay, as we have heard about one of the factors of the three with the acute coronary syndrome issues, now we will go to the second one, the growing burden of dyslipidemia. Dr. Safa Al-Tayyib, she's a consultant cardiologist and cardiac imaging, the head of Eco Lab at Al Mani Hospital, Dammam, Saudi Arabia. The new branch, Dr. Safa, mashallah. So the floor is yours.
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh.
To start with, I'm quite privileged to be among this distinguished group. It's a very special day. As I look at the audience, we are in excess of 230 attendees, actually 233. I don't think I remember the last time I did speak to such a number, and that has been pointed earlier by our chairman, that the number of attendees is really awesome. And that's very encouraging from one side. And the other side, it puts a huge responsibility on our shoulders as speakers to give the most appropriate information and knowledge. I would like to extend my thanks to Servier. They have been partners for cardiovascular protection and management throughout our career as cardiologists throughout. And without further ado, I would like to start my presentation, which was already made easier by both the chairman and my predecessor. The chairman has actually enlightened everyone about the impact of the problem of cardiovascular issue in MENA. And it's huge, it's really huge. And we meet that burden day in, day out, as I'm going to talk through my presentation, which I will try my best to keep it to the 20 minutes assigned to me. My predecessor has gave an excellent lecture, and I try to keep pace with the magnitude of the richness of it. I expected him to talk a bit about actually the impact of infectious diseases on cardiovascular burden worldwide, but probably that would come in the Q&A session. Now, I'll go to my first lecture. Sorry, my first slide. When I was preparing this
Dr.
talk,
Safa, Dr.
yes,
Safa, sorry for the
yes,
interruption. We can
yes.
see some kind of boxes inside your presentation. I think your Zoom is outdated. If you
Uh,
accept, I can share the presentation from my side. Your presentation from my side. I will give the remote control for yourself.
okay, go ahead. Go
Yeah.
ahead.
Thank you, doctor.
Can we start with this slide, please? Cumulative exposure.
Sure, doctor.
Are we on the same line? Because I cannot see your slides.
Don't worry, Dr. Safa. I will not count these minutes from your time of lecture.
Please, please. Thank you very much. Right. I have to just echo the words of my predecessor, Dr. Rabi, about very important issues, and I need to highlight them. A, the importance of the role of inflammation in atherosclerosis, and we're getting increasingly knowledgeable on that. It's not only about just the direct effect of uncontrolled blood pressure or the effect of diabetes or the effect of lipids, but there is a core issue of an ongoing inflammatory process. Not only that, he mentioned about the age, and that gives me the introduction to my slides. So we know now that there is a very important concept in assessing cardiovascular risk when it comes to lipidemia. It's a cumulative exposure, and that in very simple English is how many years of exposure to the lipid particles in apolipoprotein B. Now, it is not a surprise or a new knowledge to everyone in the medical community that we start getting exposed to LDL particles and apolipoprotein B particles as early as adulthood. So whatever we measure at the time of presentation with acute coronary syndrome or acute ischemic stroke or a transient ischemic attack or any acute cardiovascular event does not reflect the actual number of years that we were exposed to this harmful effect. Now, we as cardiologists know that when we are 3 or 4 months old, that's very early in our life as in childhood, the apolipoprotein A or lipoprotein A, which is a new player in the field of risk factors, is well formulated. So if we got a child who is already in a school age or even in the kindergarten, and I measured his lipoprotein A, that will give me a reflection of the fact that he will develop at some time in the very near future a cardiovascular event. Because the level that I measure at the school age or the kindergarten age is the same level that I measure at the age of 50. This is well known, and this is a risky factor. And that brings us to the point of age. How early should we start prevention? How early should we start medicating persons, not patients, persons? We all know that we pick patients when they present to hospital. The guidelines are based on trials that recruited people after the age of 40. But what about patients? Sorry, what about people who are 30, 35, 20, 25? The only good group of knowledge we know about these patients or these people are those with familial hypercholesterolemia, but they are not reflecting the whole population until we are faced with the fact that by the age of 40 or by the age of 50, they are crippled with a devastating acute coronary syndrome. It is sad that we know in this day and age that we can prevent this happening if we started earlier. The question is how early? How can we pick people out there in the community whom we should start medicating early? Having said that, we are practicing among an era where all the media is against treating hyperlipidemia. Every day, there is a new release in the media about the harmful effect of statins, about the harmful effect of PCSK9 inhibitors, about the useful effect of cholesterol. And unfortunately, this is a sort of information that the population like. And this is a war that we live day in, day out. Now, I will give you an example to introduce you to the term cumulative exposure. When a patient comes to you and his
Sorry,
random
sorry to
blood
interrupt,
sugar,
doctor. Sorry,
sorry,
doctor. You are on the cumulative exposure slide, right?
yes, I'm still
Because
there.
my
I will let you know when I
oh,
move.
okay, doctor. Sorry for
Bear with
interrupting.
me. There are some slides that worth spending more time because these represent the core of the presentation. So if a patient comes to you as a practitioner and his random blood sugar is 160, you know that this is a random blood sugar and it does not reflect his hemoglobin status over the last 3 or 4 months. This is why you go on to check hemoglobin A1C. That hemoglobin A1C might be 5, might be 10, and that's why you depend on hemoglobin A1C for categorization and management of the patient. And the same goes for LDL. When the patient comes to you with an acute coronary syndrome or an acute cerebral effect, and the LDL is, let us say, 70 or maybe 80, we wouldn't know how high or how low the LDL was 3 months back, 3 years back, because we don't measure unless the patient is one of the regular comers. And that gives the cumulative exposure theory. Now, the cumulative exposure in very simple English is measuring or summing the LD exposure level of an individual over the years. It's a cumulative exposure of LDL and the particles in apolipoprotein B, and that is used as a biomarker, which is as strong as the rest of the biomarker assessment to estimate the size of the accumulated plaque burden. So we know that the LDL is a precursor for formation of a plaque in the in the arterial tree, and the ulceration of that plaque is the reason why we get MIs, we get acute coronary syndromes, or we get strokes, or even peripheral arterial acute presentations. Now the whole world is moving onwards to measuring the LDL in, or talking about LDL as cumulative exposure, which is reflecting on the measurement of the personal plaque threshold, as we see here. Now, the personal plaque threshold is the number of years of exposure to LDL, added to it the harmful effect of untreated hypertension, untreated diabetes, unchecked thyroid function, obesity, inflammation, smoking, and stress of life, as we're going to see later. So, even if we are exposed to the same amount of LDL, we as persons have different plaque threshold or plaque burden. Each one depend on those factors which I mentioned. The questions is, how can we measure the cumulative exposure? Well, believe it or not, that has actually come into surface almost 6 years back. This is a graph which was produced 8 years ago and appeared in the American Journal of Cardiology, and it tells us that this level, which is 5,000, which is an expression of the accumulation of LDL measured over years, and they use mostly artificial intelligence. We all know that we are living in an era where AI is going to govern our medical practice over the next years. So we have this very well, robust, well tested graph that will tell us that exposure of this level, that's 500, that is measured, we can measure that and plot that as using modules produced by artificial intelligence, that this is a level at which the incidence of infarction happens. Now, the very simple way of putting it is, if a person has an average LDL of 80 milligram, his chances of developing an MI that's crossing the line of the 5,000 is when he is 62. While if someone average LDL cholesterol is 125, he would develop it at 40. And if it's 200, it's developed at the age of 20. So we have the information. We have the core knowledge of how we can decide on the patient chances of when he is going to develop that event, probably in align with controlling the risk factors. Next slide, please. Next, please. That would reflect on the question that was brought by my predecessor, Dr. Orabi, of how early or we should do it early. That graph will tell us two very important facts. If we started treating or lowering LDL at the age of 30, which probably is going to be in the new guidelines for lipid treatment in both the European and the American Society of Lipidology and Cardiology over the next 1 or 2 years to come, that we should go lower in terms of age. We know the cutoff age is 40, but everybody knows that we are going to go below that. We're going to go for 30, we're going to go for 35, and I'm talking about the general population that have high LDL. They don't have other added risk factor. I'm not talking about an added effect of hypertension, diabetes, smoking, and what have you. So you can imagine the turn of the practice we're going to face over the next few years to come. This is a very informative, again, this is 2024, so this is a 2 years old graph that tell you that if we started at the age of 30, we are reducing the chance of having an MI or acute event by 5%, compared to if you started at the age of maybe 60. You are going to reduce that by or increase that by 10%. Not only that, if you got two persons at different age, 55 and 40, and you reduced the LDL of the 55 years old by 50%, or this is an aggressive way, compared to someone who is only 15 years younger, but you reduced it by only 35%, you actually can improve the chances of this younger person, despite the fact that he is undertreated with less concentration reduction of LDL, by decreases his chances. You can see the curve splits earlier, and you can increase his chances of giving him more years free of attack of infarct or acute coronary syndrome. So the message from those two slides is we have to know that there is a new term. We're not talking about LDL, we're talking about cumulative exposure. The longer we are exposed to it, even if it's a modest amount, so someone who is exposed to less amount of LDL over less amount of years has an equally high chance of developing events compared to someone who is even older, but his involvement is at even a lower level. So this is important. You have to address the event early at an earlier age, and you should go higher and reduce it at a very, very early age. That actually reminds me about one of the saying of one of the icons of cardiology, that if he has a chance of spreading one drug or item in every ocean or sea in the planet, it would be the statin, because he said this is the only password that can save the human being, and it's up to everyone to believe that or not. Next slide, please. Now, from now on, embracing those two slides, I will be focusing using slides that are extracted from the 2025 focused update on 2019 guidelines of management of dyslipidemia. And this is the European and the European Association of Dyslipidemia and European Atherosclerosis Society. There are new data, mostly those data talking about the longevity of exposure to LDL or the aromatase particles, and the earlier use of that, embracing the fact that the population and the community are very much against. By the way, the war we are facing against using statins is everywhere, is everywhere. Not only that, the inertia of the doctors in optimizing management is everywhere, and we're going to talk about that as we go on. Next, please. Next, please. Right. Now, this is where I wanted Dr. Orebe to comment on. So these are risk factors that are going to increase our chances of developing acute coronary, or let us say arterial event, be it coronary, be it cerebral, be it peripheral vessel disease. We know about family history of premature coronary artery disease. We know about the hypertension. We know about diabetes. But look at these horrifying new definitions. We know the high ethnicity, those from Asian subcontinent or Asian origin, are more prone, even if they are vegetarian, even if they have very low fat content on the body, they have very high risk of developing arterial event. Stress symptoms and psychological stressors, and that includes each and every one of us. This is an era where stress is the name of the game. Social deprivation is getting worse. It's getting worse. Social deprivation because of the life we're living, because of the war everywhere, because of the status worldwide. On the other extreme is obesity, physical inactivity and inertia, chronic immune mediated inflammatory disorders, and that would be every and each inflammatory condition, systemic condition or otherwise. Major psychiatric disorders. Guys, for how long have we dismissed psychiatric patients? Oh, I don't see this psychiatric patient, please go to a psychiatrist. Now we have to wake up to the very painful fact that many of the psychiatric patients would come under our care because of genuine effects. When they tell us about chest pain, that is a genuine chest pain because of probably an ongoing acute or ongoing coronary artery disease. History of premature menopause. On the other side, preeclampsia or other hypertensive disorders of pregnancy. Remember, pregnancy phase is changing these days. The maternal age is increasing, and the assisted pregnancy, because of the use of assisted pregnancy modalities, embracing all the hormones and the hormonal treatment, increases the chances of lipid dysfunction, and not only that, the atherogenic process of the arteries. Now, instead of having the mortality, maternal mortality, having as postpartum hemorrhage or eclampsia, we are seeing more of hypertensive crisis, infarctions, spontaneous dissection of coronary arteries, and aortic dissections. These are disastrous events that we do see, unfortunately, from now on, every now and then in patients. Myocardial infarction in pregnant ladies. I'm telling you, boys, oh, it happens day in, day out. Now, human immune deficiency virus infection. When we used to go through our MCQs, we know the protease inhibitors as treatment for HIV, they increase the lipogenic milieu of the media, and they actually increase the chances of having coronary artery disease. But now we know that human immune deficiency virus itself can actually cause a deleterious effect. We know its effect on the right side. It causes pulmonary hypertension, it causes an LV dysfunction, but it does affect, probably because of the inflammation, it does affect the coronary artery status. Obstructive sleep apnea syndrome, by the way, the very old classical feature of the very short neck, the very big tummy and belly of a very fast sedentary person is changing. We are seeing loads and loads of obstructive sleep apnea syndrome in thin, lean, young patients, and we are detecting them more commonly because this is one of the things that we look for in patients coming with atrial fibrillation, and especially if there is no identified cause, the so-called lone atrial fibrillation. So we're picking more and more of obstructive sleep apnea because we are mandated by guidelines to look for obstructive sleep apnea in each and every single patient with new onset atrial fibrillation, especially if he is young and no risk factors. The C-reactive protein has already been mentioned by my predecessor. I told you already he had made my life easier by making a lot of informations in my particles or my slides already known to you. And I've already mentioned about the elevated lipoprotein A. Remember, this is the new player in the field. The new era of treatment are directed towards reducing elevated lipoprotein A. And remember, this level is well established by childhood. Next slide, please. Now, I'm not going to spend a long time on this slide. This is very well known to most of us. It just basically emphasizes how low we should go in which category of patients. We do categorize them based on moderate risk or high risk. Unfortunately, most of our patients are in this group. Even those who are not cardiologists, most of the patient would come to you after years of having their blood pressure being high at so many visits, but they are attributed to, I had a very rough time the last few days. I had a very high salt meal the last day. I'm having a lot of stress. There is always a reason for the blood pressure. By the time it formulates, there is almost usually, but not always, an end organ damage, mostly microalbuminuria. So automatically, most of the patients are shifted into either high risk or very high risk. Next, please. Next, please. Right. The beautiful statins. Now, before I go into this slide, it's not going to take long, but I would say one thing. When I was a medical student and we were doing our courses and lectures in, were given our lectures in biochemistry, our professor told us that you will not remember any of what I'm saying, but please remember one enzyme, hydroxymethyl glutaryl coenzyme A, HMG-CoA reductase inhibitor. This is the rate limiting enzyme in synthesis of the LDL, and this is an enzyme which is going to change the face of the practice in the future. I still remember those very words because it proved true. I'm not sure how many of the audience know that the inventors, there are two scientists who actually made the first statin, which is lovastatin, I think, and they were awarded Nobel Prize. There aren't many drugs that change the face of humanity. One of them is a statin. The other group, as cardiologists, we think it's SGL2 inhibitors, because that is a drug that saved millions and is still saving millions. Remember, when we talk about statins, we talk about two group of statins, moderate intensity and high intensity. And when we talk about high intensity, there are two groups, atorvastatin and rosuvastatin. Now, we're talking about high intensity because most of the patients or who are either high risk or very high risk, by default, they need more than 50% reduction in their LDL, and that can only achieved using high intensity statins, and that's on the current dose. Now, admittedly, not many patients tolerate 80 milligram of atorvastatin or 40 milligram of rosuvastatin. Not only that, we know that shifting from 40 to 80 will cause maybe only mild decrease of less than or difference of 6% or 5 to 6% to 8%, but that is at the expense of higher risk, higher side effects, mostly myalgia. But that does not mandate or does not mean that we should stop. The commonest cause of patients not getting their target dose of lipid lowering medication is doctor's inertia. Next, please. Now, this is a very interesting slide. Tell you exactly how the world outside there is practicing moderating lipid lowering therapy. The very bottom line is these are groups of patients who were discharged after acute coronary syndrome, meaning they really have to be on a high intensity statin on a high dose. And this is not a joke. Their LDL has to be below 50. It's not a matter of how much, it's how low should the LDL be. It should be less than 50 milligram per deciliter or 50% less than the admission. Remember our very initial slide, the cumulative effect. If a patient came in with acute coronary syndrome and his LDL is 60, that doesn't mean we shouldn't treat him or we should treat him with a small dose. We should go with a dose that decrease his LDL by less than 50% of his admission LDL. And even if that means that his LDL should be zero point 0 something, whatever it takes to lower his LDL. And this study is actually tested 81 regions in 27 European countries, and that is 2019. So that's not far away. That's my, what, 7 years ago? And the conclusion is instead of an increase in the dose to escalate the dose, there is a decrease in lipid lowering intensity during follow up. And that is what is called inertia. So this is in the European world. What do we do in our world? Next, please. Next, please. This is to start reflecting on what we do in Saudi. This is the 2022 Saudi guidelines for management of dyslipidemia. Please join me in observing the transition of the pattern of diseases in 1990 to 2017. Cardiovascular disease in 1990 was the leading cause of death. In 2010, it was still the leading cause of death, and in 2017 it was the leading cause of death. Many of the things have moved down. See, maternal and other disorders related to ladies and females or mental disorders have moved to the very bottom. But we are still up. Why is that? Next, please. Because, as has been mentioned, that number one killer, as already mentioned, is cardiovascular disease, and this is mostly because 1 out of 2 of people above the age of 30 are hyperlipidemic. The importance of hypertension has already been mentioned by my predecessor, but I'm raising the flag of hyperlipidemia. Not only that, the worst part is 65% are unaware that they are carrying this disastrous risk factors. As has been mentioned by the chairman, our patients are 10 years younger than their cohorts worldwide. So the longevity of our patients is reduced by 10 years compared to the patients worldwide. Not only that, we know statistically that the incidence of familiar hyperlipidemia is very relevant, and we know the definitions. Maybe this is not the time and place to mention it, but familiar hyperlipidemia is very, very prevalent in Saudi, and that's one of the reasons why patients' life is claimed at a younger age group. Next, please. The Saudi chapter of the Pure study, which is an international study looking at the prospective urban rural epidemiology study, has actually came up with the answer to many of these, or as why we're having that. Next, please. Mostly because of, next, please. Next, please. Sedentary life and obesity. Now, I must say, this is 2020 study in 2020. So this is 6 years old. And we know by the time the results are published, it depends on data that has generated over the last 5 years. I am sure this is not the status now. Every corner in the Mamlaka has a recreational center. You see many ladies proudly and men of different age groups and actually walking and strolling, especially in the winter days. So I think if we are to reread these data or to recollect these data, they would be much, much different. Or at least this is a hopeful thinking, but I'm sure this is that. But what is worrying? Look at the dyslipidemia. And that is both for men and women. The lipid status is really high, and this is, I think, might be increasing. That's the only one. If I ask me my opinion based on our daily practice, this data would might be getting worse, and this data is improving. Next, please. Next. Yes. Again, it's just telling you this horrifying results. It's an age group. Guys, the younger, this is a productive years of life, 35 to 40. Those are the age which are affected by those risk factors. But again, I'm very hopeful and I'm very certain these data, at least when it comes to obesity and sedentary life, is changing now. I'm sure it's happening now because if we collected the new data, I think the Saudi Society of Cardiovascular or Cardiac Society is refreshing this data, and I think the new data are going to be released soon and is going to be refreshing. But I will be putting my money on the fact that we are still lagging behind on dyslipidemia because of the coming slide. Next, please. Look at those very, very distressing results. This is our practice as practitioners. وما أبرئ نفسي. Now, those who are very high risk, remember the slides of very high risk, moderate risk, only 23% of those who need the target dose, only 23% of them are at the target dose. This is mostly our fault. So remember the slide where we discussed the European practice of not optimizing lipid lowering therapy. I think we're doing much worse. Actually, those who are at low risk are getting the medications. So those we are reversing or flipping the coin. We should really work on that. We should improve on that. Now we can discuss in the Q&A panel of how we can go about improving that. But this is where we take the responsibility. Part of the issue is how can we antagonize the very big war and the reputation in the media against using medications and statin, because we know very well that lifestyle alone and exercise are not going to take that risk away. Next, please. Next, please. Right. We can go next, because they are on the same slide. So the 2019 are actually giving us this result. It's recommended that high intensity statin is prescribed to the highest tolerated dose. So if you use a torvastatin, you go to 80. By the way, the only place in the world that I know of who are actually using AT is United Kingdom. The NHS guidelines would not allow you to practice that use go to giving PCSK9 unless your patient has reached a torvastatin of 80. And surprise, surprise, many patients are coming for follow-up without side effects. So maybe we should really look back again into doing that. Now, if we go to the highest tolerated dose and the goal is not achieved, then we can go to ezetimibe. And then if that failed, we can go to PCSK9 inhibition. But because that is not practiced, because of the compulsory inertia worldwide, next please, people are looking into the other thing, which is combining modest or modest amount of monotherapy with ezetimibe. So going straight from modest concentration, high intensity, modest concentration, meaning 20 instead of 40 for rosuvastatin, and maybe even 10 with rosuvastatin, and going directly to add it with ezetimibe to see the effect on the lipid lowering measurements. And surprise, surprise, they're coming up with those. I don't know if you can see those markers very clearly, but they are actually joining. This is rosuvastatin alone versus combining rosuvastatin with ezetimibe, and the pool effect is rosuvastatin ezetimibe at whatever dose, even as low as 5, if combined with ezetimibe 10, is much better in controlling lipid status when you use it against monotherapy alone. And of course, it goes without saying that the side effects are going to be reduced or compromised. So rosuvastatin ezetimibe combination therapy lower the LDL cholesterol by up to 60% and allow 91% or 90% of high risk patients to achieve LDL. And probably you are going to convince the patient more. We're going to give him a less dose, so he probably would anticipate less side effects. And that great reduction of other lipids, not only on LDL, but on triglycerides, and significant difference across other spectrum. Next, please. This slide looks into even as short as 24 weeks of therapy with combination of rosuvastatin 10 milligram added to ezetimibe effect on total cholesterol, LDL, and high density lipoprotein, and look at how significant this change compared to monotherapy in a very short time, which 24 weeks is an ultra short time compared to using it alone. So again, we are emphasizing that duration with rosuvastatin ezetimibe combination therapy resulted in significant greater improvement in all lipid parameters that we know of, and rosuvastatin compared to rosuvastatin monotherapy in patients with coronary artery disease. Not only that, next please, but we as cardiologists need to look into a very robust, sincere evidence of the effect, not only on the blood effect of lowering the LDL, but whether that reflects on the magnitude of the plaque volume. And this is an ultrasound looking inside the coronaries of the baseline look of the plaque, and after that's follow up, and the plasma volume or the plaque volume on this is actually reduced significantly when you use or compared to using the rosuvastatin alone when using both rosuvastatin and ezetimibe. It's a very good remember, ezetimibe has no side effects. Ezetimibe acts strictly on the intestine. So if someone told you that I've got a rash with ezetimibe, or it does not agree with me, because no, it does not get absorbed. Maybe it gives a bit of bloating, but that's it. It does not get absorbed. It acts locally in the intestine. Next, please. So this is a fairly recent publication in the Lancet 2022, highlighting that combination therapy is associated with lower discontinuation rates, so better compliance and better adherence in clinical trials. And we already reflected on improvement in LDL and other parameters. That has actually appeared in the guidelines 2025 with the following slide, please. Next slide. That has actually 2025 focused update. It says very clearly, if I can take you directly to this the second line, is initiating combination therapy with high intensity statin plus ezetimibe during hospitalization for acute coronary syndrome should be considered in patients who were treatment naive, meaning patients who were not on any statin, you should start forthwith. So don't go into use a high dose. This is the 2019. Remember, it tells you go on a high maximum dose. If there is no achievement on the dose, go to add ezetimibe. If there is no achievement, go to PCSK9. 2019, that was the advice, and 2025, what it says clearly based on embracing those facts that we've mentioned in the last two slides is initiating combination therapy is superior to giving maximum dose forthwith. Next slide, please. Now, I would leave you with this slide, which is again in 2025, and I think this should be embraced by heart. Now, these are the options for treatment for lipid that we have as practitioners. Modest intensity or moderate intensity, only 30% reduction. But when you go to high intensity, namely rosuvastatin and atorvastatin, you go to 50% reduction. Add to that ezetimibe and you go to 60%. If the patient is still not responding, you can add actually the PCSK9 and that will take you to the highest, which is 80%. Now, remember, there is a new group of drug which is going to be launched in the kingdom, probably in the next 6 weeks, which is bempedoic acid. I would like to draw everybody's attention to this medication, bempedoic acid. This is a drug that goes on the same line as statins, but it does not cause myalgia. So if your patient has a true myalgia, not just like aches and pains, no, a true myalgia that improves only when you stop or discontinue statin, you can prescribe bempedoic acid. Now, combining bempedoic acid with ezetimibe can increase the chance of lowering it by 38%. And if you add to that the PCSK9, that can go all the way up to probably maybe 80% or 70%. Guys, we have all the options. This is a very rich menu. No patient who has high cardiovascular risk should go out of our clinic without protection. We take full responsibility. إلا من أبى. I think we have a very strong media antagonism that we are tolerating day in, day out. This is the job of not only the clinicians, this is the job of the media that should antagonize the other media, including companies like Servier that should actually start to join, align a war against the media that are going, because this is the only way we can protect the patient early in early life. Now the guidelines are moving towards earlier age with higher doses for better life protection. And I thank you very much for your time.
Thank you. Thank you very much, Dr. Safa. Very nice. And as you went on your slides, telling every time that your life made easy by your predecessor, Dr. Talal. And for me, with Dr. Talal lecture and your lecture, I don't think I should give any lectures by now.
Oh, you are welcome. You are the boss, يا دكتور علي. الله يحفظك.
Allah يخليك. So again, this is the QR code if you want to join the medical WeBook. I'll be very brief. And with my talk, we will be finishing the 56% of our patients, because our typical patients are hypertensive, dyslipidemic, and diabetic as well. And as I have mentioned earlier, if you allow me to speculate, that the background of all the problems is the predisposition by our genetics and the lifestyle we have gone through since the 70s and the 80s, and we are just seeing the results. Can I have the slides, please?
Doctor, we didn't go to a presentation to our side.
Well,
Uh,
I
to-
have it, and if you want me to share it from my side,
Yes, doctor,
because
please.
I was informed that it will be displayed from you. Okay, shall I press on share?
Yes, doctor.
Oh, where is that one? This bottom share. Mm. Okay, it is asking me for link. Are you on control now?
No, doctor. There is a green color button
Where is
for
that
share in
share
the Zoom.
bottom? Hmm?
Go to your Zoom application, doctor. There is a green color share button on the below.
Let me. Okay. Okay. Again, can you take me through where is that the sharing? Share. Yeah, here I got
Yes,
it. The
doctor.
green one.
Exactly.
Okay,
You
screen.
can see your application mic PowerPoint slides. Can you see it on the list?
I put the share.
Yes, doctor. Perfect. You
Okay.
can screen mode, presentation mode.
Mm-hmm. Where is that presentation?
You can see right button. Yes, doctor. Yes, that's one. It's
Okay.
amazing. Thank you.
Okay. So now we will go to the metabolic factor. This is my disclosure. And as we have just mentioned from the epidemiology, that the MENA region has the highest prevalence in 2019. And from 2014 till 2020, sorry, from 2000 till 2014, we have moved in position. But unfortunately, we are still at the highest among our region in the epidemiology, in the prevalence of diabetes. This is very clear that we have a genetic predisposition, and the obesity and the urbanization with poor nutritional habits are the leading cause. I totally agree with Dr. Safa that if we do the statistics these days, we might find these inactivity improving, but to what extent, I don't know. But let me just give you something about this combination of inactivity and food bad habits. Whatever you do activity, you cannot overcome the bad nutritional habit. If you are inactive, you will be very, very much in need of a very strict nutritional lifestyle. So having this combination will make it more easy and more doable and getting more reasonable way of lifestyle rather than 3-4 months as usual. If we look at the real life study, which I am very much liking these days, because they reflect the reality rather than the standard studies condition, which showed that the hemoglobin A1C is still away from what we want. If we take it in general as a hemoglobin A1C of 7, I'm not going to go as strict as 6.5, although it is needed in some patients. We are far from there, especially in our region. We are at 8.7. This 8.7 is an average in Saudi Arabia, where some centers, especially the diabetic centers, are having much better than these numbers. But unfortunately, other centers' number, when they were combined with this pool of patients, they bring that number much higher. And as you can see, globally, we are not winning in spite of what we have in hand from the medications. So the diabetes is responsible about things which are preventable. This is the thing which we have to put in mind. We are not talking about things which we cannot handle. No, if we control our patient's blood sugar, blood pressure, and lipids, we can prevent amputations, prevent the sight of our patient, and prevent the kidney disease, the heart failure, and the heart attacks with strokes. You see how much these numbers are increasing around the world? Angina, retinopathy, cardiac failure. And we have a cardiologist with us today. They call it the malignancy of cardiology. 130% increase and 95% increase in renal replacement therapy. I hope by these drugs we are having at this stage, maybe at 2025 data will reflect their effect on our patients. This is the standard classical slides of the microvascular complication. You all know, which I have to remind myself and remind you always about it, the retinopathy, the nephropathy, and among the neuropathy is the erectile dysfunction with the peripheral painful neuropathy. And these things are preventable. When we go to the macrovascular, the cerebrovascular accidents increase by 2 to 4 fold. Coronary artery disease, by being uncontrolled diabetic, 8 to 10 folds. Peripheral vascular disease and the foot amputation. If you go and look at that slide where the risk hazard ratio, but just by looking there, when you see all the points on one side, that's mean you have a synergistic effect of diabetes over cardiovascular risk factors, by which the presence of diabetes amplify the detrimental effect. So all these points are in the increased risk factor. And when we look on the another slide, just being a diabetic with the same condition of LDL, it will boost your risk by so many percentages. But, and if you still have the same level of the LDL, there is a lots of explanation on that. The LDL become more aggressive. LDL small a, above a, B 100, all these factors, and the dysfunction of the endothelial is part of the hyperglycemia. So although LDL level is the same, but the risk factor, the cumulative life risk factor, boosted when you become diabetic. By the impact of cardiovascular importance by reducing 1% in A1C, how much benefit we can have, all these with a very nice significant p-value in the reduction, and very nicely illustrated here that 43% reduction in peripheral amputation and the peripheral vascular diseases, fatal, non-fatal MI, all are carrying a very good risk reduction by only reducing the A1C by 1%. It is not easy. It is achievable by having no inertia, not reduced inertia. We shouldn't have inertia. When we go to the study, which will not be replicated anytime in our life, I think the UKBDS, which finished in 1997, presented in Barcelona. Now they have a follow-up until 2021. You see the legacy of controlling the patient's blood sugar on that time, where any diabetic endpoint related factor were 12% in 1997. They continue observing. There was no intervention in 2021, but it's still at 10% in 2021. See how beautiful is early control of blood sugar will be benefiting your patients in the myocardial infarction, in the microvascular disease, and all-cause mortality as well. The microvascular and the macrovascular benefits of intensive glycemic control and early intensive control was also shown in 12 unique RTCs involving 52,500 and more patients. The non-fatal MI, the microvascular outcome, the retinopathy, and the neuropathy. The consequence of the delay, increased microvascular complication, increased macrovascular complication, and of course, increased mortality. Okay, when we go and read and say this word in our lectures about the routine care, the routine care is not a bad word. The routine care shouldn't be just filling the patient's prescription as it was when his hemoglobin A1C is above 8, when his LDL is above 160. I'm not saying 100, Dr. Safa, and his blood pressure is above 140/90. This is not a routine care. This is bad care. And when we combine this routine care with delay in starting of controlling patients, how much of the cumulative incidence of cardiovascular effects will happen to those patients. And when we go on the other side, and we go what is called in the studies as an intensive treatment, and combine it with as early as the beginning and the first 3 years, how much of these complication can be prevented. So when we look on these things, difficulties in having controlled patients' blood sugar because of the way type 2 diabetes can increase the blood sugar. So in order to reduce the blood sugar, we have to come and attack it from 8, from 13, whatever our omni is that in that years for the mechanism of diabetes. And we have drugs now, which is much better than before in attacking these blood sugar and reducing it from several ways. If we take the new in the block SGLT2 inhibitors, and we take an example of the existing in practice in Saudi Arabia, the IMBA and the DABA, how early their benefits in reducing the death from cardiovascular causes, and the early separation of slides in the IMBA, and also it was shown in the renal specific composite endpoint for the DABA as well. Another new and very much affecting the pathophysiology of type 2 diabetes, because it is reducing the blood sugar and reducing the weight of the patient through satiety and feeling of full, is the GLP-1 class. And this GLP-1 class is showing beautifully the reduced in hemoglobin A1C and in the body weight. With this combination, the primary outcome of reducing the cardiovascular risks and events are very evident in the non-fatal MI and the renal, and now the new indication of hepatosatiety as well. What about our goal? Our goal is not reached if you are practicing endocrinology, diabetology. You cannot control your patient by 1 or 2 drugs. If you are really serious about helping your patients and targeting 7 and below, you should use more than 1 drug. And we cannot go and use only those new classes and go ignore one of the insulinemia condition, which we have to have more insulin from the pancreas and using the sulfonylurea because it stimulates insulin secretion. Sulfonylurea are not the same. The sulfonylurea are different, and the glycoside have a unique property in reducing the cardiovascular and micro and macro complication. 6.5 A1C was achieved in the advanced study, and believe it or not, the control, the standard practice improved at that time, and it was baseline 7.3. When you go from 7.3 to 6.5, this is really difficult job. I'm not talking about getting it down from hemoglobin A1C of 8 and above. It is 7.3. And the stability of control of A1C is very elegantly showed in the advanced trial. And when it was studied against the DD before sitagliptin, it was much reducing the A1C significantly than the sitagliptin. What about the effect of sulfonylurea from the beginning of the diagnosis until its effects fade away? The average is 8 years with the other sulfonylureas like glibenclamide. But here with glycoside MR, we have reached up to 14.5 years. The anti-diabetic medication have a problem with weight increase in their some classes, especially the sulfonylurea. And it was shown in the FAT study 8.1 kilo, in the ACCORD study 3.5. In general, UKBDS demonstrated 1.7, but in the advanced study, there was 0 increase in the weight. So glycoside modified released has been associated with renal protection. And this renal protection was showing by a reduction in the albuminuria, which is very significantly linked to the cardiovascular complication by 15%. And it is shown here how much new cases was reduced, how much worsening was reduced, and the onset of new macroalbuminuria was reduced by 30% as well. And 65% reduction in going to end stage renal disease. So by this, I will go to my take-home message that the type 2 diabetes is a progressive disease. We cannot control it by single drug, maybe 2 in some patients, but most of our patients, excuse me, are on 3 drugs, and we will reach insulin at some stage. The early control, securely and crucially important in the diabetes management. The glycemic control was and is still an important aspect of management patient with type 2 diabetes. Glycoside MR is an effective anti-diabetic agent with a strong evidence of safety, especially on weight and hypoglycemic attacks, and efficacy, and we should be considered as one of the options in the management of type 2 diabetes. A beautiful fountain of Jeddah is my logo in all my lectures. Thank you very much.
Thank you, Prof. Ali. Thank you.
So now we will open the floor for the Q&A part, if there is some. And I have received This is a question for you, Talal.
You're welcome, yes.
How do the data in your presentation apply to your clinical practice? Rule of endothelial dysfunction in hypertension and cardiovascular disease. Which guidelines do you refer to?
So all the guidelines stated that the importance of early detection of hypertension and initiation of AC inhibitor in the treatment is encouraged. So how we can reflect it on our clinical practice? This is a very excellent question. So genetics and family history. So if you have a patient who is having his father and his probably a next skin relatives who had an acute myocardial infarction at age of 50, his paternal and maternal grandmother, she had a stroke recently, probably at age of 55, 60. So you are anticipating this patient, he's having an predisposition genetically for hypertension that can be difficult to measure an endothelial part, but is in the clinical part, it can be reflected by a genetic predisposition and early detection. So many of our colleagues, they are seeing many patients in the clinic, and they're saying this is white coat hypertension, white coat hypertension, and they are not digging more that this patient is having a strong family history of hypertension. A white coat hypertension could be unmasked during the clinical visits, but you need to be very meticulous before you are diagnosing a white coat hypertension. Again, picking up a high risk patient in your clinic, I think this is a pure clinical judgment and depends on the physician and how his skills is applied in the clinical practice. But please don't miss any patient with high risk factor and keep these patients coming frequently to your clinic without risk stratifying him based on his genetic predisposition, his lifestyle, his previous reading, his home reading, and you can take it from there.
Thank you. If the asking person on this question for Dr. Safa allow me to modify his question, you mentioned the importance of early statin therapy starting from 30. I don't think you mentioned so. You said it may come in the next guidelines to 30. So the question, and it's a very nice question, for cumulative cardiovascular risk, do we have data that statin is safe over a long-term therapy of 20 to 30 years? Dr. Safa?
Well, this is a very nice question, and I will just have to use my basic knowledge on how do statin work. We all know the term pleiotropic effect. Remember, the big box of the statin treatment, it does not only reduce the lipids, it modulates the plaque, which is already formed, so it stabilizes it. So the thick gap that is covering the plaque is well preserved and it is thick. We don't want it to be breached. It reduces the volume of it, and that is measured on CT scan. So we know how to look at the plaque, we know how to measure it, we know how to measure its activity, and we now know that C-reactive protein, the high sensitivity C-reactive protein, goes parallel in actual to the activity of the plaque itself. The other thing, it I think the colleague who asked the question might be getting into the possible side effect of glycemic dysfunction of the statin, which has been known for a while. And I must say that it is a very, very mild side effect, and it is less than, it does not reflect on the actual number on hemoglobin A1C, and it does not stop or preclude the effect of many thousands and millions of prescriptions of a statin that are produced day in, day out. So the very unequivocal answer, this is the only treatment that on the long term is going to improve the survival, is going to stop many of the upcoming events, And that is, we have to embrace very, very clearly. There is one thing that actually has been counteracted by all the communities, the cardiology. Everybody is having this side effect of it is responsible for future happening of dementia. That is a very well known, documented as capital N, capital O. No, it does not cause dementia. It actually protects against future event of microvascular dysfunction. So put it in every part of the body, it works beautifully. If this is an answer I have to give, I'll have to give it confidently. This is the only drug that I can prescribe, and I put it with my hand on my heart and say, it's going to change your life.
Thank you. We have a lots of questions, but because of time, I'm going to select one of the question which was addressed to me. So I'm going to read it as it comes. It is said that the era of sulfonylureas is over due to the cardiac and side effect and weight problem after glucophage. We should go directly to the DB4 inhibitors and then other modalities, but not sulfonylurea. And he asking for my response. I don't think this is fair for sulfonylurea, because sulfonylurea are not the same. And as we have seen in our the slide, that the glycoside micronized release advanced study, which was a very long time study, has shown no increase in weight, and there is no cardiac effect, which was shown in the FAT and the ACCORD study, which has been stopped. The advanced study was not stopped, and there was no increase in cardiovascular risk. It is still one of the modalities of treatment, and especially in the characters of patients whom you think their insulin level is low. So he will not benefit from other modalities exactly the same way that he will benefit from the sulfonylurea, namely glycoside MR. This is a proven effect, and it is one of the modalities, because your job at the end is to avoid side effect, yes, is to avoid cardiac complication, yes, but bringing the hemoglobin A1C is something which we are there for our patients, is to control their blood sugar. I think by now I'd like to ask if there is any home taking message from the survey people, or we will like to thank our audience, which we have reached 248, Dr. Safa, and thank our speaker, Dr. Talal and Dr. Safa, for their elegant lectures. And I think each one of you should deserve an activity by its own. As this is the first wave, this might be a message to survey that ebook should go from now on to tackle one of those three in each other wave. What is your say there, Fuad? If we have somebody from survey and
thank you so much, Dr. Thank you so much, Dr. Ali, for the presentation, Dr. Talal and Dr. Safa. Great meeting. Thank you so much. I'd like to thank you and the audience for being here. Surely we'll have other activities related to similar to this, for sure.
Thank you very much, and bye-bye, and have a nice weekend.